Our speaker today is Dr. Roby, who is a research scientist, senior research scientist in the center, and an assistant professor in the School of Public Health and the Department of Health Services, where he also is the associate director of the Masters in Public Health program for the department. Dr. Roby has been doing a great deal of work on healthcare reform, a number of projects collaboratively with the center, but also with colleagues at other universities as well. Dr. Roby has a background in studying the delivery system and with special emphasis on the healthcare safety net, which he did nationally, working at George Washington University in the Center for Health Policy and Research, Health Services Research and Policy there, and also with the National Government Association for that. Pleasure to have you talk about the supply of physicians, primary care physicians, under healthcare reform.
Thanks. Hi, everyone. So, do you want me to use the microphone?
Yes, please.
Yes.
Is that okay? Everybody can hear? All right, so today we're going to talk a bit about kind of the potential of a bit of a conceptual framework that we developed here to look at the issue of primary care physician supply, what the drivers are of demand and supply on both sides, and then how that framework can potentially be impacted by healthcare reform, specifically direct provisions related to healthcare reform that specifically target primary care physician supply and changes to the workforce, while there are other indirect provisions of reform, like expanding insurance to almost everyone, that certainly have an impact on demand and also how care is delivered. And I think that there's probably 15 things on each side that you could argue are really going to have a significant impact on either demand or supply or both. And so you had a handout that I got from the American College of Physicians website that simply runs through some of the grant programs and workforce residency programs that have been identified by physicians groups as affecting physician supply specifically, and how that was worked into the healthcare reform law. But I would probably argue that it goes much beyond that. So hopefully this presentation will give us a chance to kind of discuss and think about how all of these aspects of the healthcare system come together in this demand and supply function. I did want to thank not only the Physicians Foundation that funded this work last year, but also my co-authors, Anna Davis, who couldn't be here today, Zena Cali, Anna Martinez, Nadi Parat, and Jerry Kaminsky, and also Janet Kaufman from UCSF for her very good feedback on the report. So the study goals were really to understand existing trends in primary care physician supply prior to PPACA, the Patient Protection Affordable Care Act, also known as healthcare reform, understand the potential changes to PCP supply given the current trends, and then identify the distribution of the PCP shortage across different practice settings, provider types, to kind of understand that interchange. And then really look into geographic and market factors that are likely to influence both supply and demand. So first we set out in kind of consulting the literature on a conceptual framework to understand primary care supply. And I'll spare you the really difficult chart that shows the actual conceptual framework. But in general, we had on the demand side, population growth and aging, chronic illness burden, care behaviors in terms of where people are going to seek care. Are uninsured people going to the ER, as we often hear? Are they going to community health centers? Once they're insured, how will that change things? Things like income, insurance status, unmet need, and geographic location. On the supply side, we did a very comprehensive literature review that led us to the following three domains: human capital, environmental, and financial, where human capital includes things like the actual number and distribution of PCPs practicing and where they're practicing, how many hours they're practicing, who's being hired, who's retiring, the training capacity in terms of residency programs, career choices of trainees, we all know that we're kind of focused on this specialty care style environment in the U.S. and that you make more money if you're a specialist. So training primary care physicians and actually having them go into primary care can often be a struggle. Looking at efficiency and volume in different scenarios, including an exploration of panel size. On the environmental side, we looked at practice setting, so whether things are going on in outpatient clinics, federally qualified health centers, private physician offices, and how we expect that to change or potentially be supported by the healthcare reform law. Regional practice variation, role of nurse practitioners and physician assistants, which is a very important issue considering that we aren't able to put out enough physicians to meet demand and many projections for demand, and how the NP and PAs will be involved in our future system and the current system. Also, we looked at the financial issues. So that financial domain boils down into commercial insurance rates, Medicaid payments, Medicare rates, including at the time we were doing the report, there was a lot of controversy over the sustainable growth rate, whether that would be implemented or delayed more, which it was. And also managed care penetration. I think in California we have a very different model of care than in other states because of the fact that managed care is still fairly alive and well, not only in the commercial market, but very much so in the Medicaid and Medicare market. So I just want to go through all of the different domains here. So first we looked really at demand. So it's kind of shaped by population growth and aging, increasing prevalence of chronic disease, so this higher level of disease burden that's being felt in aging populations, and also just in young people. We've shown obesity rates are increasing that are very likely to result in increased diabetes risk, increased hypertension risk, increased heart disease risk later in life. And trying to project that out can be a difficult task, but I think everybody understands that having a sick young population will certainly not pay dividends in the future when people are aging and are potentially on Medicare and things like that and needing more health care. Income and access to insurance. So this is a very intricate association here where higher income people who work in larger firms are very much more likely to have access to commercial insurance. People with low incomes that have disabilities, that have families, are much more likely to have access to Medicaid. But there's this spot in the middle, and I won't call it a sweet spot, maybe a sour spot, where you have lack of access to low-income subsidies, but you have bad access to commercial insurance. And so what's happening to that population? I think in 2014, the idea is that all these people will potentially have better access to health care through insurance sources, and if that will improve things for them in terms of meeting the unmet need that they've been storing up over the past few years, and that kind of pent-up demand issue, and what impact that'll have on the health system in general in the short term and in the long term. Also, care behaviors, so people understanding how to access care. Do they need to go through a gatekeeper? Do they need to get a referral to see a specialist? Do they have very significant cost sharing, so they delay care for a significant amount of time? Are they going to get second opinions and third opinions with specialists and getting care from specialists that should be done by a primary care physician? All of that was considered, as well as geographic location. In a state like California even, let alone the nation, you end up with very different geographic needs depending on the characteristics of the population in the area, as well as characteristics of the provider population in the area. So in an area like San Diego, where you might have a higher undocumented population that tends to be somewhat healthier, younger, tends to be working but not have access to insurance, you may have a very different style of care and ability to go access care than in Miami, where we have lots of Medicare beneficiaries in retirement potentially. Growth and aging in the U.S. population. So we looked at kind of the gender differences there as well, and you can see here that right here is kind of where we are in 2000 and 2010. So you can see that the share of the population, even though the population will be increasing quite a bit, you can see that the share of the elderly population will be increasing substantially, while the share of the younger population is kind of stable. So we would expect, because we know that the younger population is far less likely to use healthcare and really incur significant healthcare costs, the elderly population is much more likely to use more healthcare and incur significant costs. And that trend holds up for both women and men. you can see that the share of elderly women will probably be much higher than the share of elderly men, whereas everything else is fairly stable in terms of increase and distribution between gender and age differences. So the total supply projections, and these are from DHHS sources, estimate that 952,000 physicians will be needed by 2020, and this is specialty and primary care. Approximately 35% are currently working in primary care, so they also projected about 39%, I believe, 371,000 primary care physicians would be needed by 2020 at the national level, and kind of balancing, and this is based on a balance between the need they perceive prior to healthcare reform and the supply that they would need to meet it. Yeah.
The previous slide, when you talk about the expectation of how many primary care providers are needed, is based on the current style of practice.
Yes, absolutely. Yeah. So, I mean, we'll talk a bit about this when we're talking about the healthcare reform bill. I think there's a lot in the law that we don't know how it'll shake out yet. What is an accountable care organization and how it will impact physician practice. If the incentives are changing enough to really change the way a physician practices, our panel size is going to go from 2,300 to 4,000 because you have 3 NPs working with you to coordinate care for the chronically ill patients, and of that use of resources and how it could be distributed differently. I'm just guessing here, but I'm assuming physicians will be relatively resistant to change. And I don't want to offend anyone in the room, but if we look at published articles now, 20 years from now, physicians will actually be using them to do evidence-based care, and that's kind of the trend we've seen historically. And so we're still likely to follow that. And in the same way, payment reforms, bundling, ACOs, all that isn't all that prevalent now. There will be pilot and demonstration projects to test out things, but we're probably not going to bear those dividends or see those dividends until 2020, 2030, 2040. So I think that in the short term, we do have this concern about immediate need to train primary care physicians to catch up with demand, but at the same time, like we saw in the 80s, all of a sudden we end up with a surplus of physicians, and there's concern about that, and closing medical schools and cutting residency caps and things like that. So I think there's always going to be this push and pull, and because there seems to be a lag in terms of adoption of technology, adoption of evidence-based medicine, practice is always going to be changing, and that would happen with or without healthcare reform. And so I would probably argue that healthcare reform doesn't have as serious an impact on physician supply as everybody's making out to be. More of the change is going to be due to aging and chronic disease burden that was going to happen in the absence of healthcare reform already. So, one of the points I wanted to really underscore in this presentation is that I don't think there's a national crisis in primary care physician shortage. I think there will be very much geographical crises in certain states, in certain counties within states, and even certain MSAs or cities within states. So you can see here that the U.S. average of primary care physicians who are practicing per 100,000 adults is about 113. We exclude children from this primarily. We included it in the final report, but for the most part, there has been good evidence that pediatricians are in good supply, and the ratio of children to pediatricians is fairly good. There is some concern about pediatric specialty care. However, because this is a very primary care-based focus, we kind of didn't discuss that issue much. But in terms of primary care, children seem to be pretty well taken care of. However, on the adult side, we see a lot more deficiency depending on what state you're in, what area you're in, and what your characteristics might be. So we see here that Mississippi kind of brings up the rear in terms of supply of physicians by state. Utah is second, whereas Massachusetts is the highest with something like 145 primary care physicians in practice per 100,000 adults. California kind of falls in the middle somewhere right here, with a little bit under the U.S. average, but still a substantial portion of physicians practicing primary care. So you can see that the needs could potentially be very different, but I would argue that we can't just look at this table. We have to look at a little bit more. So you can see here that we have the 10 highest and 10 lowest. So we just look at this table, we say, oh, well, Mississippi and Utah are in for bad things, and Vermont and Massachusetts will be fine. That's not necessarily the case. And so what we did was we used multiple different indicators of supply and compared them by states. So here we have the Milken Institute State Chronic Disease Index rank, which ranks states from lowest chronic disease rate to highest chronic disease rate. And then we have percent of population age 65 and over, percentage uninsured, so that's kind of a proxy for pent-up demand and people delaying care due to cost or due to lack of insurance, as well as the number of PCPs in patient care per 100,000 adults. So you can see here that in a state like Utah, where we say, oh, they're in for it because they don't have enough physicians, they have the lowest chronic disease rate in all of the land. They have a fairly low percentage of people over the age of 65. And they don't have a very high percentage uninsured. It's kind of in the middle, around, I think, 12% if we had the full table here. So even though they have low physician numbers per 100,000 population, there hasn't really been a lot of complaint about physician access in Utah at this point, and so we can probably hypothesize that they wouldn't have as much of a problem with dealing with implementation of the Patient Protection Affordable Care Act because of the fact that they have a kind of middle-of-the-road uninsured rate where people will be taking up insurance, but they're not going to use that much care immediately. Many of them are relatively young, and so there may not be that same supply issue that we would expect in a state where there is a high uninsured rate, there is a high chronic illness rate, there are low numbers of physicians, and it's an older population. So Pennsylvania is probably a fairly good example of a state where they're 45th, so fairly high in terms of chronic disease. They have a very high elderly population, 15%. They do have a 10% uninsured rate, which is very good, but they could potentially, even though they have a high number of primary care physicians in practice, not be able to keep up with the demand that could occur from the uninsured patients that are older, are chronically ill, entering the market and starting to use care. But it really depends on more information that would be needed at the Pennsylvania level, at the local level around demand and supply, where those people are insured and that type of thing.
In the uninsured rate, all ages?
This is all ages, yes. So it's probably very likely that one of the reasons why this uninsured rate is low is because they have a very high over 65 population that already has Medicare. And Pennsylvania isn't known for having a immigrant population that hasn't met the Medicare threshold, so they're likely to have fairly high elderly insurance rates. So this gives you an idea of kind of the changes that we could potentially see in how the federal government is keeping track of these things. So HPSA is Health Professional Shortage Area. So it's a determination made by the Bureau of Health Professions at HRSA every few years. And right now we have 65.7 million people living in health professional shortage areas in 6,277 different identified HPSAs. And you can see here that this is the percent of population in each state living in a HPSA. So we often think of California as, a place where we have very high uninsurance rates, we have problems with access to care. However, we're actually fairly low, kind of a little bit under the median in terms of the percentage of people living in HPSAs. So, and this speaks to the geographic issue a bit in that California, as a state, probably isn't considered to be a medically underserved area, but we do have these pockets within the states where medical underservice is a problem. So, city of LA is a perfect example where we have kind of a healthcare desert in South LA where MLK Drew closed. We don't have a lot of access to primary care, and it's basically met by community physicians that are willing to take discounted payment or provide free care, federally qualified health centers and other clinics, but there's no major hospital there. There's and it can be difficult for people to get care. And so 2 miles away, you're not in a HPSA, but 2 miles south and you are in a HPSA. So I think California, it speaks to the issue of we really need to get down into local level indicators of workforce as well. And unfortunately, the data isn't all that readily available, and it becomes difficult for the federal government and often at the state government level, the Offices of Statewide Health Planning and Development, to have the data available to do really robust planning for supply and predicting demand at the local level. Instead, we end up having this argument at the national level, which I think is a bit of a fallacy, because even though we think overall we have this shortage of physicians, in actuality the shortage is divvied up into different states, and it may not be an issue for everyone. So putting resources where they're needed is probably the appropriate way to go. Unfortunately, we don't have the evidence base to put those resources where they're needed in many cases. So you can see the difference here where Louisiana and Mississippi are very high, where 64% of the population living in HPSAs, whereas in Nebraska only 8% are living in HPSAs. And of course, this is a much higher number than we actually see uninsured. So there are some numbers out there about medically disenfranchised populations versus the uninsured, and that number is often higher because even if somebody's insured, they may not have access to care. So some recent research came out of George Washington University last week on the 26th in New England Journal of Medicine, and their hypothesis was around that the greatest mismatches in supply and demand will occur in states where the Medicaid program is the least generous in terms of eligibility and benefits, and also have a very high or have a very low PCP number per 100,000 population. So California, because we have relatively generous Medicaid program eligibility levels, would be less likely to have shortage issues due to the Medicaid expansion portion of the bill than other states might. So this is the Access Challenge Index score for each state, and so they're basically saying that Oklahoma, Georgia, Texas will face the largest barriers in terms of getting the low-income uninsured into Medicaid and getting them care versus states like Vermont, Massachusetts, and D.C., where the Medicaid program is already covering lots of the uninsured or the potential uninsured, and because of that, they already have fairly robust networks to deal with them. So the pent-up demand issues will be less in D.C., Vermont, Massachusetts versus Oklahoma, Georgia, Texas. You can kind of see the ratio occurring here.
So Dylan, just to clarify, their hypothesis is based on the amount of expansion that's going to occur. That states that have the least generous programs are actually going to have to expand quite a bit in order to meet the new requirements in 2014.
That's correct.
Okay.
So Texas will have to go from, I think, 28% of FPL on average to 133. That represents a much larger change than California will have to undergo. And because Texas also has a low primary care physician to population ratio, they kind of are facing this risk of having a less adequate network to deal with all these newly insured people. I think the concern still isn't completely founded if they don't have enough information on the Texas population to tell us whether or not they're actually going to need care and if they have pent-up demand. Community health centers in Texas have been very successful, and so the uninsured population in Texas may not have the same issues that an uninsured population in another state that didn't have the same investment in local and safety net types of providers. So again, the answer can be a bit difficult. So the shortage projections before passage of the ACA were 35,000 to 44,000 primary care FTEs by 2025. So this is based on that original number from DHHS, but then this is getting down to the actual mismatch between projected supply and demand. And so these numbers are from the AMA and the AAMC, I believe. So there was going to be they projected by 2025 we already have a 29% increase in demand due to aging and chronic illness without reform. And after reform was passed, they came out with another report saying that, well, we expect demand to increase by 4%, and I believe they didn't really adjust for the fact that there was some workforce investment. So they're adding that they would need as many as 66,000 primary care FTEs by 2025. But again, healthcare reform has much less of an impact on need than this increase in demand due to aging and chronic illness. So now we're going to get a bit into predictors of supply. So again, we have these three domains that everything kind of fit into for our theoretical framework: human capital, environmental, and financial. Human capital tended to be shaped by total health professional training capacity. So in terms of what programs existed for residencies that trained primary care, where they were located, versus areas where there was a lot of specialty training going on, and what how the ACGME, the Accreditation Commission for Graduate Medical Education, was handling residency caps, residency slots available. And that can be a kind of glacial change that could occur in ACGME, where it's very difficult to tell a hospital they're going to lose a bunch of residency slots and it's now going to be a primary care slot. So we can't expect that to change overnight and be available, new trainees being available to deal with primary care by 2014. We also looked at trends in career choices of trainees. So there has been some evidence around level of debt being linked to likelihood of picking a certain specialty or primary care, income, lifestyle in terms of number of hours, where somebody wants to live. Gender, there are some gender differences in terms of patient hours and specialty. Perceptions of the specialty. I teach a class in the medical school on healthcare reform, and the 12 students, they say, well, I don't want to just go into primary care, I want to go do a specialty. And so it's kind of this perception of primary care as a lesser specialty, or can potentially be damaging to supply because of that perception. Also preferences in terms of what you want to do, if you have the wherewithal to continue on additional training for longer residency programs, for fellowships, that type of thing were very much linked to supply. Number of lifetime FTEs per PCP was also a human capital variable, and we're looking specifically at things like hours in patient care by specialty, retirement age, and also attrition. So we've seen a lot of evidence of physicians moving from primary care specialty into research. I'm sure, probably 10 people in this room do 30% clinic hours and 70% research time because they find research pleasing and exciting, as I do. And so even though we're counting them as a licensed physician, are they providing enough patient care to really let us understand kind of how the supply differences change? So there is an issue with data available and how we're tracking that data. Also, geographic distribution of PCPs. So we've already talked about the state issues, efficiency and capacity of different styles of providers, as well as trends in international medical graduate availability and location. So the actual number of physicians and trainees is it's actually increasing. So we're actually, contrary to popular belief, we are producing more physicians and more people are going to primary care. However, we aren't producing enough to really catch up to this potential shortage in supply. So 39% of the 952,000 newly trained physicians that are needed, according to the DHHS numbers, are expected to practice in primary care, and they're still saying that that's not enough to keep up with this demand and change. And that's potentially due to aging, chronic illness, and care behaviors. The number of actual slots has decreased over the past 20 years for residencies, but we tend to be getting international medical graduates and other switches into primary care. Also, we have about 20,000 physicians in primary care per year retiring. And if you look at all of the at data from medical students, only about 5% or less want to practice primary care when they're first surveyed. And so you have this issue of perception about whether primary care is a worthwhile profession.
Did you say what the number of current practicing physicians is?
No, I did not.
Can I just ask?
Yes.
I've seen the figures about only 5% of current medical students wanting to go to primary care, and yet there's still a projection of 39% are expected to practice. How do we, and given all the incentives to move in the other direction, how do we actually have any anticipation that 4 out of 10 will actually end up?
Right. Well, so I think, through the matching process, potentially luck of the draw and your grades and numbers gets you into the specialty you want to practice. So if everybody wants to go into dermatology, through the matching process they don't match anywhere and they're scrambling on match day to find a place that'll take them, they may end up in some internal medicine practice. Whether they end up being in a primary care residency program, whether they end up being a hospitalist or ending up trying to specialize in critical care or something like that, we don't know. And so a lot of it's kind of conjecture around, even though 5% or less when they enter medical school, I believe, want to practice primary care, do their opinions change, and does it just become natural selection where they end up in primary care because the competition was too stiff at certain levels? And, that's a perception issue as well.
And the other issue is geriatrics. The big issue is even if they go into primary care, they're not going into geriatric care. And I don't know if you're going to talk about that.
I will not be talking about geriatric care specifically, but I think there is certainly a need there. I think that's the next thing on the iceberg that people want to chip away at. I think the concern there is that perhaps we don't need to train a bunch of geriatricians. We need to enable geriatricians to work with internal medicine docs to make sure that they know how to deal with aging populations. But I think, geriatricians tend to have some calling toward entering that specialty, so I think that's a difficult one to get at as well. But I think the first priority in terms of a lot of people's minds is to deal with the overall primary care shortage, and whether that means having a bunch of NPs practicing primary care or a bunch of specialties picking up the slack, that could be an appropriate way to deal with it in the short term, and then we can get into planning for actual specialties. But again, because it does tend to be rather volatile, it's difficult to predict supply of a specific specialty out 20, 30 years. So I don't have the number of...
in 2010, it's something, it's close to 700, then 670 or something.
I feel like it is. 800? Okay, 800,000. So I spoke a little bit about lifestyle and patient care hours, and I think, and this one kind of shows that the overall number of patient hours has been decreasing over the past few years. This is older data for both men and women, but you see that women tend to provide fewer patient care hours than male physicians, and this could be due to lifestyle issues as well as kind of the specialty they end up practicing. So women are more likely to go into primary care specialties, but they're also more likely to work fewer hours. So you have to think about that when predicting FTE need for caring for the population that we expect to use the system over the next 20, 30 years. So this is the percentage of active physicians who graduated from international medical school. So you can see here that in certain states, the U.S. average is about 25%, or a little bit less than 25%. The state median is about 17.3%. But depending on what state you're in, you may have a high supply of international medical graduates who end up going into primary care specialties in many cases. I think Ross Medical School basically produces, I think 96% of their class goes into internal medicine or family practice. And so it could be a strategy to help this along, that where we do end up granting more J1 visas, we do end up kind of targeting more international medical schools to send graduates to deal with this issue of supply of family practice and internal medicine, because our U.S. graduates don't necessarily want to go into those fields. And depending on how successful residency relocations and residency swaps that might occur within the healthcare reform package, how successful they are, we could look at using external sources for supplying more physicians. So I think this brings up a big question in terms of what do we expect from our physicians going forward. I think if we just use this old traditional model of we need lots of doctors to take care of people, and we have to just keep churning them out and training them and making sure they continue practicing and work more hours to meet that need, we're probably we're fighting an uphill battle. It's probably Sisyphean or something, where we just keep worrying about the current model and keep dealing with the crises as they come up, rather than trying to change the model a bit. So right now, the private practice panel is about 2,300 people on average per year. So we have to think about how do we assist physicians practicing in this kind of 15-minute visit environment where you have to churn through 4 or 5 patients a day, you're constantly running back and forth.
You meant an hour, right?
Yeah, an hour.
4 patients. You said a day.
Oh, sorry. 4
That's a specialist. I had to see 5 patients today.
4 to 5 hours.
Hopefully not.
So how do we assist physicians practicing in that style of environment? So can we use medical assistant panel management? Can we use community health workers to decrease demand, or the medical assistant to help the doctor kind of triage their patients by their appointment style and have the doctor show up for 5 minutes, but the medical assistant be able to provide coaching, provide advice on medication adherence, that style of thing. And I think, as I said before, 20, 30 years from now, that may be a very feasible way of practicing medicine. But I think in the current climate, only certain physician groups and certain practice settings are friendly to that model, and kind of giving away that autonomy that the physician might have. Also, we're going to see additional efficiencies from health information technology. Will we be able to reduce demand by training patients better on how they're supposed to access care, that they don't need to come in for a refill, or changing the way that that technology is used in order to improve the care that's provided to patients without requiring the traditional office visit and requiring that billing to occur. So paying for email visits, paying for group visits, paying for phone consults, that type of thing. In the Federally Qualified Health Center panel model, by law, they are only allowed to have a maximum of 1,500 patients per physician. A lot of them are dealing with a very high chronically ill population, 40% uninsured, 35% Medicaid. So they certainly have needs in terms of managing chronic illness, and in theory their visits should take longer. But because they do have medical assistants and NPs and PAs providing a lot of care depending on the state you're in, I think we can learn a lot from the FQHC model in terms of how that care process is occurring, even with a high demand, kind of disenfranchised low-income population that could be catching up because they've been without care for so long. Alan?
Oh, yeah. So the numbers just calculate out on a 15-minute visit with 2,500 patients and approximately 2,000 hours more working year. That calculates out at about 4 visits per patient per doctor per year average. If you get 2,300 patients, about 2,000 hours of work week, it should be 1 patient per hour. So if it's 15 minutes, that would imply that patients are coming about 4 times a year. So reducing visit frequency using assistance.
The 15-minute visit is more anecdotal. Most physicians don't use that as a rule, right? This is the average panel size, 2,300. You see as high as 2,500 in many locations, and of course we have a bunch of docs doing 1,500 people and less. In a lot of FQHCs, they have an 800-person panel, depending on where you are. I do think that 4 visits per person is probably a little bit high. I think we're on average seeing about 2.5 per person throughout the country. However, there are lots of people who use 10 plus visits a year, and so I think there's a concern about how do we strategize around that high need population, figure out a way to better take care of them without just churning out a bunch of docs that are going to fall into the same archetype.
The good thing is that often you get 30 minutes for a new patient, right? So hopefully providers, there's attrition for all sorts of reasons from practice, and you are taking on some new patients as well.
Sure. Yes, Michael.
I just wanted, I agree that the comment for your previous slide about the community clinics being a good model is an important one, but I think the other thing that's important to keep in mind is that most people are not seeing the community clinics. Most people are seeing small practices, so 2-3 person practices, and so that's the context for the great majority of visits that are happening. That part of sort of the challenges, because those places have constrained resources, and implementing these type of challenges is sort of the new frontier, as well as getting an idea of quality.
You would think I paid you to make that comment. So this is for me to jump up on my soapbox for a second. I think we focused a lot on kind of separate vendors supplying disease management and the Kaiser population care management approach and that type of thing. And that is very possible in a large system or within an FQHC where they develop some chronic care model that is very established and they have quality improvement structures and they have data. But I think having a 24/7 nurse triage line and having health coaches and things like that isn't sustainable for a 2 to 3 person office in an independent physician practice. And so I think as healthcare reform says, well, we need to develop these patient-centered medical homes, we need to develop these structures to integrate care and coordinate care, it's very difficult for an independent physician in their solo practice or their partnership to develop that kind of capacity. And so I think we do need kind of local overlays of chronic care management programs that may be operated by the county, they may be operated by a nonprofit, to enable the physicians to actually provide the type of service that would be needed in a patient-centered medical home. So maybe they all share EMR resources, maybe they all share a nurse triage line, but a consortium of 50 docs get to join in, and that one organization would be paid a per member per month or some sort of fee to manage that. But in our current reimbursement model, that's not all that possible. And so I think we need to figure out ways to develop these umbrella organizations, or at least umbrella services, whether they're at the state, county, local, or medical group level, to help physicians to deal with the increased demands of a population and provide good care, while also considering that they don't have enough time to deal with all those issues at the bedside or in the exam room. So in terms of supply, we looked a little bit at environment. So practice setting in terms of FQHC versus private practice versus HMO model is very important, as well as urban-rural setting. So I think a lot of the HPSAs are in rural areas versus urban, but then we see pockets like South LA where you end up with an urban-style health professional shortage area. Also, there's a lot of information about regional practice variation. So the Winberg and Fisher Dartmouth Medical Atlas ideas around certain areas practice very efficient, safe, high-quality care. Others spend a lot of money, it's very resource-intensive, and we don't see any difference in outcomes. There's a lot of controversy there, and I think physicians are wary of those findings, but I think there potentially is a lot of truth to them with some caveats. Also, state regulations can be very different in terms of the environment in which the shortages may occur and the disconnect between demand and supply may occur. About 55% of states require physician involvement for nurse practitioner provision of primary care. All of the states require physician involvement for physician assistant provided primary care. In addition, most states that even do allow NPs to practice independently pay about 80% of the Medicare rate, or of the Medicaid rate, or the Medicare rate for NPs to bill. And so there is this disconnect, or this kind of hierarchy in terms of NPs get paid less, and in some states they're not allowed to practice independently at all. And so physicians, of course, can potentially have issues with NPs as competition. So I think it's important to kind of take a step back a little bit and look at how the states are doing that are providing lots of NP care, what the outcomes are, and if there's any truth to this idea around the differential standard of care between NPs and PAs and physicians, and also what we can do as a nation moving forward, or even as a state in terms of planning, to figure out ways to integrate that care better. So do we just have independent practice NPs, or do we have these team-based approaches where NPs are able to join into a practice or provide some services through some other organization, through the medical group, for example, that would enable physicians to meet the needs of the population without giving up that autonomy, but also taking advantage of these newly trained, for the majority, well-trained individuals who might be coming out of nurse practitioner school rather than medical school. And another thing in there is related to the fact that all NPs don't go into primary care, contrary to popular belief. Lots of them, PAs and NPs, go into specialty care. So at the same time we're dealing with this lack of attention to primary care in the physician realm, we're dealing with the same thing on the NP and PA side. The last domain is financial in nature. So physician participation in Medicare and Medicaid is very highly linked to our concerns around physician shortage, especially related to implementation of the ACA. So as we know, in California, Medicaid rates are fairly bad for independent physicians and outpatient hospital facilities. For federally qualified health centers, the rates are decent, not great, but they're usually commensurate with Medicare rates because of the fact that the Public Health Service Act says that they should get cost-based prospective reimbursement. So we're likely to see with this Medicaid expansion that we need lots of community health centers to take the burden of the Medicaid population in the short term, and that's why you saw $11 billion of PPACA going directly to community health centers to expand and add sites. In addition, there's potentially money for the states to expand temporarily Medicaid rates to the 100% of the Medicare level for 2013 and 2014, I think with the hope of expanding the network a bit and hoping that those physicians stick around after 2014 when they go from getting $80 a visit to $22 a visit. Maybe not a good guess. And I doubt California will say, oh, this is a great idea, we got lots of these Medicaid doctors back in the system, let's just keep the rates as they are because of our budget situation. So there's a lot of state variation in Medicare and Medicaid fees depending on geography, overhead, malpractice on the Medicare side. And also if you look at the way that fees are set in Medicare HMOs, it's related to the benchmark rate, which there's a disincentive for being efficient and saving money. And so I think we need to revisit the way in which Medicare and Medicaid fees are made and move away from this very fee-for-service based way of providing care, but also intelligently designed bundled payment ACO reimbursement mechanisms that will enable us to move forward on the supply side. Managed care penetration is also very important. As a condition of taking signing a health net contract, you may in LA County have to take care of 20% of your panel being a Medicaid patient in the health net Medicaid managed care plan. That isn't present in every county and every state in the nation, and so there is a concern that in states like California, where you kind of have a captive provider audience for the Medicaid managed care population, that doesn't really exist in other states, and so managed care penetration could really have an impact on provision of care and whether people can fit onto a panel and whether they're able to take on the role of a patient that is going through kind of gatekeeping styles of care and is willing to kind of partner with their physician in terms of primary care provision. Also, commercial and employer insurance reimbursement. In terms of specialty care reimbursement, in terms of competition within markets, potentially you could draw, supply and choice of specialty and where you're practicing is very much related to the insurance market you're practicing within, the negotiated rates that are going on, and the competition there. So in LA, UCLA is able to drive a very hard bargain and walk away from the bargaining table with health plans because they want a certain rate, whereas in Riverside, the community hospital can't walk away because their only other competition, or doesn't need to walk away because their only competition is the regional medical center. So this is a chart of HMO penetration rates. You can see that California is still very high, even though we've heard that, I think Jamie Robinson said, managed care is dead, but California tends to be alive and well. And so, but it tends to be in the public market for the most part. The waiver just created an expansion of managed care and higher managed care penetration within the next 6 months. And so in states that have high Medicaid managed care penetration, you may have less of an issue of pent-up demand and supply than you will in a state that's completely reliant on Medicaid fee-for-service. So this is just a table showing kind of the distribution of states that pay badly for Medicaid versus Medicare. So you can see here that we're in this 5 states over here where, on general, we pay less than 50% of the Medicare rate, whereas there are 6 states that pay the Medicare rate or better, and the other half kind of pay 80% and up of the Medicare rate in Medicaid. We have to be cognizant of the fact that everybody's insurance will not be equal. They will be coming from different styles of care. They'll be coming from Medicaid programs that are managed care only, Medicaid programs that are fee-for-service, Medicare HMO, Medicare fee-for-service, and every employer could be out there negotiating different rates through their ERISA self-insured plan, and so it's very difficult to tease out the issues with what are the uninsured that are now getting care going to look like under the ACA, because we don't know what the exchange will look like. We don't know what employers will do in terms of grandfathering, in terms of deciding to self-insure and meeting the conditions of the mandate. So the way that rates are negotiated will be very different. And if Medicare gains a foothold in terms of funding these pilot projects around, or allowing these pilot projects around ACOs and cost savings and cost sharing, shared savings, you could end up with a very different world in 10 years where bundled payment and shared savings are the name of the game instead of fee-for-service. But until we hit that point, I think it's very difficult for us to predict the link between supply and demand. So in terms of PPACA impacting our theoretical framework, we have new access to insurance as well as changes to insurance rules kind of impacting the demand side. So people are going to get Medicaid, people are going to get new insurance under the exchange. Then we have changes to insurance rules around guaranteed issue as well as how much they need to spend on medical care. So for the medical loss ratio numbers, 80% and 85%. Will that drive health insurers to actually just allow more care to occur, and what pressure will that put on premiums moving forward, as well as the supply of medical care for the population that's demanding it. Also, I think there are concerns around, if we have new rules and access around preventive services, is everybody going to rush out and go get a preventive service because it's now free? And I don't think we've seen that currently, but when people have access to insurance and there's no cost-sharing burden, we've seen from the RAND health insurance experiment and other studies that it will potentially increase need. However, I would probably, realize need. I would probably argue that we want to see that kind of shift. We want to see people using value-based purchasing power rather than not getting the screening and having access to care when they get diagnosed with cancer in a late stage or something like that. On the primary care supply side, so I would kind of argue that some of these changes will have indirect results on the supply side, but they're really targeted at demand, and the opposite is probably true as well. So on the primary care supply side, we have pretty significant training grants for nurse practitioners and PAs, for training for physicians to learn how to work better in teams and to manage a high-risk population. There's a lot of community training grants focused on that same issue. Also, the National Health Service Corps, a lot of this is described in the ACP handout. National Health Service Corps is getting money to potentially expand the number of people that it would allow loan forgiveness if they practice in an MUA or HIPSA for 3 years or more. And so the number of slots that will be made available could potentially help community health centers staff more of their positions, and some evidence has shown that where you are trained ends up being where you end up practicing. So if we're able to push more training in and kind of early career placements in community health centers in rural areas where NHSC is willing to pay the bill, then we might be able to deal with a little bit of that shift into rural and needy areas for healthcare. There's also a provision that allows for residency space reallocation, where unused specialty slots could be reallocated to another program, another residency program in a primary care specialty in a different area. So you might see a urology residency in Texas that's open, if it's historically open, would be moved to a primary care placement in LA County. There's going to be a lot of fighting about this. Lots of Southern California family practice residency programs didn't get a raise in their cap, they didn't get any new slots, and they're in areas that need it. And so I think over the next 10 years we could potentially see some change here, but I think there's always going to be somebody who loses out when these reallocations occur, so I think we need to be a little bit more cognizant of where the need is, and also thinking about increasing the cap on an as-needed basis rather than making everybody operate under this overall global cap that occurs in ACGM. There will also be physician assistant and NP demonstration projects that should impact the environmental kind of practice setting side in terms of training NPs and PAs to work better with physicians and take some of the burden off in terms of panel and dealing with chronic illness that we expect most of the demand to be located in. Also on the financial side, we have ACA incentives and fees, as well as changes to Medicare Advantage bidding. So Medicare Advantage payments on average will probably end up going down potentially, because the plans will be getting less money depending on the area due to being at 95% of the benchmark rate or 115%, whatever it's linked to, where you might have physicians less likely to decide to care for Medicare HMO patients, but I think that will vary depending on where you're located. Also, there are fees related. There's a 10% bump for primary care delivered through Medicare. For certain CPT codes, there's the 100% of Medicare bump for Medicaid fees temporarily, and also bundled payment and all these different incentives that could be created through ACA to develop more efficient ways of providing care will impact the financial side, but potentially the ACO model could indirectly affect, will certainly directly affect the environmental side as well, in terms of how practice is actually done, how the standard of care is delivered under more efficient circumstances. In terms of recommendations, some strategies for increasing physicians are to increase U.S. medical graduate capacity. So increasing the number of people we're training, increasing the number of residency slots. However, I would caution us about just deciding that upping physician fees and training more physicians is going to solve the problem, because I think it won't occur fast enough, and there's been some evidence that from Tom Rice in the early 80s, I believe, about physicians hitting a certain level at which they don't need to practice anymore They don't need to see any more patients because the marginal utility isn't that great. They already made enough to pay for the, I think Sandra Basrani at the VA always says you need to pay the pool man. So if they have enough money to pay the pool man and they have enough money to pay for the Lexus, then do they need to provide that one more visit at a low $22 Medicaid rate? So I think we need to be, the old model is put more physicians into the system and pay them more for primary care. And whether that is appropriate probably isn't. There's a lot of argument on both sides.
You forgot to pay off their school loans.
Yes, that's true. So debt is certainly an issue as well. But you can always go work on a National Health Service Corps site, and then you don't have to worry. Increasing J-1 visas for international medical graduates. Right now, states have up to 30 waivers per year. So currently, if you train as an IMG, finish residency, you have to return to your home country for 2 years or obtain a 3-year waiver to practice in an MUA. However, states only have 30 waivers per year to do that with. So expanding that cap could potentially be helpful. And just in terms of increasing the proportion working in primary care, of course we have increased incentives for primary care practice, perhaps loan forgiveness, perhaps reinsurance programs that allow you to take on financial risk or be part of an ACO, that type of thing. Kind of realigning of reimbursement for primary care and specialty care. There's a lot of concern about RVU rates and evaluation and management codes versus procedure codes, and the fact that procedure codes tend to get more payment, more weight, rather versus evaluation and management. So it disincentivizes primary care physicians from potentially practicing because they kind of have less reimbursement to actually collect on. Improving perceptions of primary care in terms of provider satisfaction and lifestyle. I mean, I don't know, a bunch of primary care physicians that have a very flexible lifestyle, but if you are able to figure out ways to get primary care viewed as a specialty in which you work in a large medical group or you work in a very cohesive environment and there is a lot of ability to share patients with other providers, manage the panel better, you have NPs and PAs who are able to help you care for your panel, then maybe the lifestyle issue gets better, and so it becomes an attractive discipline for folks who aren't willing to work the 80-hour week or whatever it might be, and just keep doing procedures to develop, to get higher RVU rates. Increasing lifetime patient care hours is also a consideration. So in this current economic market, it's not hard to get physicians to delay retirement, but in the future we could, once the economy gets better, you could end up with an exodus of primary care docs. And I know in Boyle Heights, for example, I've heard some anecdotal reports that there isn't a single physician that in a independent practice that's under age 50. So once they retire, there will be a gap there that won't be met by people being trained to go take over their practice. Increasing the supply of NPs and PAs in primary care is often considered a good solution, potentially, but there is this concern about MDs and NPs sharing the same type of cases, sharing the same type of responsibilities in primary care. So I think we need to think very carefully about balancing the increase in autonomy for NPs and PAs and increasing reimbursement for NP and PA care while also integrating them into the physician-based practice model, rather than just saying we're going to have two different models of care, the minute clinic with NPs staffed with a list of 80 things that they can treat very easily and that they have the scope of practice to treat, and MDs that care for all the really sick patients that can't deal with the urgent care minute clinic style. And then you end up with this kind of adverse selection into the physician practices, and you can't spend 15 minutes on the patient, and reimbursement may not be commensurate. So I think we have to be careful about just increasing the number of NPs and PAs with primary care in mind. Increasing efficiency of existing providers. There is evidence that health IT could help, but at least in the first 2 years, there's been evidence that it actually hurts productivity until they learn how to use the system and are able to adopt it and start taking advantage of all the different features. Increasing multidisciplinary team-based care with NPs and PAs with medical assistants that may be paid less than a physician but provide a very important piece of the care puzzle, especially for the chronically ill, is considered a good solution. Reimbursing for telephonic and web-based care, increased use of telemedicine, specialty consults over the phone, over the internet, and reimbursing for those is also potentially helpful. And increasing the use of allied health professionals in that team-based model. Also improving the distribution of providers, so building medical schools and residency training programs in rural and underserved areas has been considered a good solution. one other aspect that was included in the healthcare reform law is that community health centers would now have the ability to have their own community health center training programs. So instead of Cedars having a primary internal medicine residency that rotates through Watts Health and St. John's Child Center, they would actually be able to adopt their own programs, have residency slots, and develop that capacity internally. And then you end up with a provider population that knows how to practice in that environment and is also willing to take on that type of population in terms of a Medicaid uninsured population. So there has been a lot of evidence that where you train and where you go to residency has an impact on where you end up locating as a professional physician. Expanding those successful incentive programs, NHSE and Title VII loan repayment. I think one of the concerns here is that I think Title VII, as every year, they're kind of up for cuts. They never get the appropriation that they're authorized for. And considering our current political climate, it's very possible that even though Republicans are angry about the individual mandate and the Medicaid expansion, they're not going to be able to cut those because that money has already been appropriated. But they can cut appropriations for NP/NPA demonstrations. They can cut appropriations for Title VII funding. And so they're going to be cutting on the edges, and a lot of that will impact potential supply and training physicians for this new model, but it's not going to cut the insurance exchange and the mandate. And so you're going to end up with lots of demand and not a lot of supply because the two elements weren't integrated well in the bill because they're kind of considered separately, and the appropriation's been made for one and not the other yet. And then we already talked a bit about rebalancing RVUs and E&M versus procedural codes, also considering paying for care coordination and patient management services, or establishing those organizational supports to allow nurse triage, kind of chronic care management processes to go on in places that aren't historically set up for it, like an independent provider practice. And then exploring payment mechanisms through Medicare, currently through these pilot projects and demonstrations around bundling, global capitation, pay-for-performance, and other models besides the fee-for-service mechanism. Another big thing I think that needs to be addressed, and it's somewhat being done at the HRSA level as well as the OCTAD level, is planning for workforce development. There have been short-term grants given out by HRSA to OCPOD to plan for workforce development, but I think we really need to develop the resources and data structure to enable us to track supply and demand at a relatively real-time level, if not real-time. And creating national indicators of access, leading indicators, could potentially be very helpful. And Susan Skillman from University of Washington talks about this a lot. If we have something like unemployment rate or number of patients that have a certain number of days in delay, we know what to do about physician supply in that area. Do we have a public health team that goes out there and meets that short-term demand? Do we temporarily allow the cap on training to go up? Because we know that 2 years prior, if we see a high rate of people delaying care at 15-day delay, and that's going to end up being a 30-day delay in the near future, we need to figure out a way to deal with that demand very quickly and enable us to have an informed decision-making rather than this always coming up as a policy issue and dealing with the crisis one at a time rather than having a very systematic, evidence-based way of dealing with it. And I think our data strategy could potentially be helpful for that. So
you're saying we need to reenact the 1974 National Health Planning and Development Act?
Perhaps.
To reinstitute health planning.
Well, yeah, and you could probably...
That was defunded in 1982 by the Reagan administration.
Right. So, I mean, if there's federal money for it, I suppose. But I think it could be done very much as a... I think it has to inform planning, and I'm not sure that... I'm sure it would require specific legislation, but I think states could do this, where if they have the ability to show ACGME that they have need, then potentially, as long as the state has good data and infrastructure to report it, and they have proof that these certain leading indicators will lead to shortage in the future within the next 5 years, and that they can deal with it if given the appropriate resources, then it could be kind of an ad hoc way of dealing with it rather than an extremely systematic kind of national bureaucracy that we may not be able to get through in the current legislative climate. No?
Sort of, is this sort of like a medical needs SWAT team idea?
It could be, I think. In federally qualified health centers, for example, if one of them is in trouble and they're running out of money or there's mismanagement, HRSA will step in, send a consultant, give them short-term loan money, and get them back on track. Because HRSA is not interested in closing health centers and getting rid of a site that's taking care of the uninsured and Medicaid population. I think you could follow the same model at the state level, at the county level, at the national level, around issues like primary care physician supply. And maybe you do have, there's lots of traveling nurses, traveling physicians that could go practice temporarily in an area to meet a short-term need. But I think hopefully what would happen is that you would be able to plan better for residency slots. So you might not get a residency cap adjustment forever, but you get 5 additional slots in 2011 to deal with the perceived shortage that will show up in 2015 when they're about to graduate. So I think we just need to be able to plan a little bit better, and whether that requires federal legislation or it's something that's done on an ad hoc basis at the state level remains to be seen. Also, decreasing future demand for care. I think we expect the health insurance kind of pent-up demand curve to kind of spike up and then remain at a lower level. And even though it'll be at a higher level than if you were uninsured, there should be some leveling off of demand. So once we hit that first demand spike, potentially if we're using value-based care, if we're using public health, prevention, wellness, and changing the incentives a bit through ACOs and other payment mechanisms, perhaps we can start to decrease future demand for care, or at least future demand for inappropriate and non-effective care. And that is contributed to through comparative effectiveness research, it's contributed to through ACOs, contributed to by not reimbursing for hospital-acquired infections. And so I think there's a multitude of ways that this could happen. It's not clear that it'll all converge at the same time this will actually occur. We also should, this is kind of an Ed O'Neill idea from UCSF, consider a structural overhaul of the U.S. healthcare system, redesigning teams, focusing on this kind of cultural coverage and evidence-based medicine and appropriate care, and empowering members of the team, similar to the aviation analogy in patient safety, to take on different responsibilities and take on different roles and be able to deliver very efficient, very cost-effective care that ends up resulting in better outcomes than we ever saw from the regular traditional model of primary care-based medicine. So there's quite a bit of research needed in order to do that, and data needed. So state and local standardization of data is currently available. There's a lot of data available nationwide, but I think some states lag behind in terms of availability of data. I think California has better data than most states. So at the national level, we certainly need to expand that ability and enable for DHHS or ACGME to have that data through administrative reporting, know the number of hours, things like that, so they're not reliant on surveys for everything as they often are. We also need to know more from surveys or other methods about wages, working hours, other predictors of supply that come up, rather than just number of licensed physicians, where they're living or where their license is held, and where they're potentially practicing. We need to know more about the dynamics of the practice and potentially how much they're being paid, what the hours are, things like that. Also, we need a better idea of prediction of demand, so investing in state or local health interview surveys, investing in provider reporting on leading indicators, so we do know I'm having trouble seeing patients. It's a 6-week wait time for a specialty visit. It's a 6-month wait time for a surgery. We need to know that in real time rather than it just being based on anecdote and being the first time we hear about it is in the LA Times when somebody dies waiting for care. So I think we need to be a little bit more focused on having the data available to make those evidence-based decisions. That's about it for me. Any questions?